The study that I presented actually is a confluence of kind of two research strategies. The first is really the use of PET imaging after induction chemotherapy to try to sort out, the preferable chemotherapy combination to add to radiation prior to surgery. So this really builds on the results of the Calgb80803 study, which was a large multi-center study that was performed throughout the US. So what that study did was that it randomized patients to one of two induction regimens, either FOLFOX or carboplatin paclitaxel, and then repeated a PET scan after 6 weeks of chemotherapy. If there was 35% or more decrease in SUV uptake of the primary tumor, that was considered response. So a responder continued with the same regimen during radiation followed by surgery, while the non-responders switched to the other chemotherapy regimen with radiation followed by surgery. So a surprising finding of that study was that patients who got induction FOLFOX responded by PET and then received FOLFOX radiation seemed to do the best. So they had a pathologic complete response rate of almost 40%, and the median overall survival was the best. So based on that, we then modified an ongoing study that we had, which originally added Durvalumab, which is an anti-PD-L1 antibody, to carboplatin paclitaxel radiation, based on the fact that FOLFOX seemed like it potentially was superior, and certainly based on the fact that it was just well tolerated as carboplatin paclitaxel radiation, we modified our current study design, to the current study design. So essentially what we start with is 1 month or 2 cycles of FOLFOX. We then use a PET scan to figure out if patients are responding. If patients are responding, they continue with 5-FU oxaliplatin during radiation, or capecitabine oxaliplatin with radiation, and we precede that with Durvalumab, as well as one additional treatment of Durvalumab during the chemoradiation. On the other hand, if someone is not responding to the FOLFOX by PET, we switch to carboplatin paclitaxel with radiation, and also add in the Durvalumab as in the FOLFOX patients. Everyone then has surgery, and then post-surgery, patients receive 6 months of adjuvant Durvalumab as a maintenance treatment. So with that kind of long, introduction, the study accrued 36 patients, which is the planned number. The primary endpoint of the study actually is pathologic complete response rate. And at the time that we presented the data, 3 patients had yet to undergo surgery. But of the remaining patients, the conclusions were that overall adding immunotherapy to chemoradiation was tolerable and feasible. There certainly were some immune-related toxicities, but for the most part, they didn't prevent us from completing the radiation or the surgery on schedule. In terms of efficacy, we also have seen a promising efficacy signal. A little bit more than half of patients have either a pathologic complete response, complete disappearance of the cancer, 100% treatment response, or 99% treatment response, where our pathologists assessed that there was, a minimal amount of residual cancer. So to have half of patients have, a 99% to 100% treatment response certainly compares very favorably with our historical data, certainly compares favorably with the CLGB data. So I think putting it all together, I think the conclusions are that adding immunotherapy to chemoradiation is feasible, although we really have to watch carefully for immune-related toxicities. I think there are promising efficacy signals, and certainly this warrants ongoing phase 3 studies that are adding immunotherapy to chemoradiation, either as preoperative or definitive therapy. The one other comment that I would add, which is tangentially related to our study, is that we now know that giving adjuvant immunotherapy for any patient with an esophageal cancer who has chemoradiation and surgery and who fails to achieve a pathologic complete response is a beneficial strategy. And this is based on the Checkmate 577 study, which found benefit for 1 year of Durvalumab. So certainly our study also incorporates a period of adjuvant treatment, which is now considered standard of care.